Good day to everyone out there in the myeloma world. From myself, Kelly Cox, Senior Director of Regional Community Workshops, and the whole IMF team, we welcome you to the Regional Community webinar that we're putting on today. We will be talking about many items that are going to help you as a patient and your family members and so forth with all aspects of myeloma. We have been doing this type of programs at the IMF, from patient family seminars to regional community workshops to scientific meetings, for over 31 years. We've been doing this longer than anyone else out there, and we've been supporting so many people that it's countless at this time. We'd like to go, next slide, please. Where is that? Okay, I'd like to thank our sponsors. It's Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, and Takeda Oncology. When you see you're going through watching this video or watching this webinar, you might have some technical issues. If you do, go to hold on a second. I got to close something just popped on my screen. There it is. If you have Q&A, send questions to our support team who will reach out to assist you. You can also email us during the webinar at meetings@myeloma.org. As a follow-up today to this workshop today, the speakers, slides, and video replay will be available shortly after this. So if you're writing and typing too fast, take a breath, slow down a bit, and understand that if you didn't catch everything, we'll provide this to you later at a later time for you. That's better for you to write things down. The other part that's incredibly important to us here at the IMF, your feedback. Your feedback. We need you to fill your feedback survey out after you're done with the meeting. It will help us understand what we need to bring in the future, understand how we can support you better. So please just take a moment. It doesn't take that long. Next slide. So here's a little rundown of today. You're hearing from me right now, Kelly Cox, Director of Support Groups and Senior Regional Community Workshops. I've been with the foundation for almost 20 years now, and I can't say how much I'm proud of all the people I work with. Then you'll have Dr. Ganguly from Houston Methodist. He's been down in Houston for 4 months right now, so let's always give him a good warm welcome. Then we'll have a Q&A with panel, and that will be of Ann McNeil, Dr. Rafat, and Dr. Ganguly. Then we're going to do a little stretch break, something new we're trying. So I really do need your feedback on this when you fill out the forms. Then we go into relapse therapy and clinical trials. This is so important, along with understanding Myeloma 101 and frontline therapy. You have to understand what relapse therapy is and clinical trials. Then we have another Q&A with the panel. And then we come up to how to manage myeloma symptoms and side effects. Put your notepad down during this one, just listen, and this is going to help you with so many aspects that deal with myeloma after treatment and during treatment. Then we'll have some more questions, and then I'll say goodbye. So without further ado, I'd like to introduce a friend of mine that I've been working with for, we just figured it out, 7 or 8 years. Dr. Ganguly, I call him Sid, is now with the Houston Methodist Hospital, I believe, or Houston Methodist at Houston, Texas. And he started many programs across the country. So they're thrilled to have him down there, and we're thrilled to have him here today. So Sid, take it away.
Thank you, Kelly. It's a very nice introduction. Kelly and I go back, I think, more than 8 years. Out of your 20 years of service, which we all thank you for, we've been doing this regional workshop for the last 8 to 10 years in Kansas City. Before I delve into the Myeloma 101, just want to give you a little bit of background. Many, many years ago, I was actually trained from Houston Methodist and Baylor College of Medicine. And after that, I went to Kansas and worked there at the University of Kansas Center, developed the myeloma program for 19 years. And that's where I met Kelly, and we developed our myeloma program, a very strong myeloma and amyloidosis support group. Every year we held this very well appreciated regional workshop, but then COVID hit us and we did not stop. We did even last year virtually, because I think it is important to keep up with the advances that is happening in the field of myeloma, and all for the better. And then I moved to Houston, and I have been here for the last 4 months. And Kelly and I talked and said that we need to continue this tradition. We need to build a strong myeloma program here. And that's one of the reasons, and that's one of my mission and vision here at the Houston Methodist Hospital. And I've been here for 3 months, and I'm basically happy to say that I'm back to my alma mater, back to my home where I actually started my career. Without any further ado, we can go to the next slide. As Kelly was saying, that we do need to understand the myeloma 101 to understand where we started and where we are going. So just to give some basics, which many of you already know, but some of you might have been introduced to this disease either through personal experience or family or relatives, and this is something new. Myeloma is a cancer of our immune system. The name of the cancer cell is called plasma cell. Normally, plasma cells make normal antibodies to fight off infections and foreign invasions. But in myeloma, for some reason, those plasma cells become abnormal. And when they become abnormal, they proliferate and they start making an abnormal antibody, which on the left upper panel, you can identify by doing a blood work called serum protein electrophoresis. And that spike with a star on top, that should not have been there. And that's what is called a monoclonal spike, or M spike, which is one of the hallmarks of having a monoclonal gammopathy, which multiple myeloma is one of them. It can be a full antibody, or as you can see in the lower panel, it could be just the light chain, which also we have the capability of measuring, especially kappa and lambda, 2 different types. And if the ratio is tilted, then it's also important to classify that as a light chain myeloma or light chain monoclonal gammopathy. When those plasma cells start increasing in number inside the bone marrow, then it eats away the bone. And you can see on the x-rays, the hallmark, what we call is lytic lesions on the skull, or it can eat away a vertebra and can cause a vertebral collapse or a fracture, and sometimes even can cause a long bone fracture. And these abnormal proteins can also plug the kidney tubules. And often I've seen patients coming to see me as a first manifestation when the kidneys are not working. So multiple myeloma is actually a multi-system disorder, and it can affect every organs of our body coming out from our immune system, and hence patients are immunocompromised and very high risk of infections, pneumonia, etc. On the right upper panel, you can see those large, deep blue cells, and many of them actually look very, very abnormal. And some of those cells may even have 2 nucleus instead of 1 nucleus. Next slide, please. Which can remind you of someone else. And that's, of course, a joke. Next slide, please. So the earliest evidence of myeloma we might have seen in one of the Egyptian mummies, where they had found out vertebral disease or plasmacytoma. Next one. But in the modern medicine, the definition of myeloma actually came from England, where this woman, very clearly depicted in one of the journals and the papers, where her bones were deformed. And one day she was in front of the fireplace resting with her husband, and suddenly she felt a snap in one of the thigh bones. Her husband picked her up, came to the nearest hospital, where unfortunately she passed away. And an autopsy was conducted, and the pathologist mentioned that the bones had a red grumous matter, thick and lumpy, which now we know was full of malignant looking plasma cells. She was actually treated. At that time, the treatment was not available. She was treated with orange peel and rhubarb. Of course, you understand, he did not do very well with the orange peel and rhubarb, but we have come a long way from that to today. Next slide, please. So multiple myeloma, unfortunately, in majority of the patients is an incurable illness. However, I must say, when I started my medical school, compared to where I am now, I have been seeing at least 15 to 20% patients in my practice that we treated and did a stem cell transplantation and then maintained. And I do not have any evidence of myeloma 10, 15, 20 years. Are they cured? Maybe, but I'm using that word very cautiously. Most of the patients with myeloma start off with a relatively benign condition called monoclonal gammopathy, where the bone marrow does not have excess plasma cells. You can still see the M protein in the blood, but the patient has no symptom. As we get older, actually this MGUS is more prevalent. Almost 10 to 12% patients above the age of 70 or 75 may be walking around with a monoclonal gammopathy of unknown significance because 80% of them would not progress. However, in some of those individuals, it does progress to the next step where the bone marrow now has more plasma cells and it spills into the category of smoldering myeloma, but still the patients are asymptomatic. But they still have a 50% chance, but some of them, which we call a high-risk smoldering myeloma, will eventually turn into a symptomatic myeloma. And you might have heard about the acronym called CRAB, hypercalcemia for C, renal failure for R, anemia for A, and bone lesions for B. Once that manifests, then we have a definition of multiple myeloma. Now, there are other newer definitions even without the CRAB. For example, the light chain ratio involved over uninvolved more than 100, or the bone marrow plasma cell more than 60%, or MRI showing more than 1 lesions, it still can be classified as active myeloma. And then the patient needs to be treated and they go into remission and relapse. And eventually, because of multiple genetic aberrations and mutations, some of the patients can turn into refractory relapse and may even turn into one of the really aggressive case called plasma cell leukemia. I'm not going to touch on that. It will be Dr. Abinor who will be talking about the relapse refractory phases. Next slide, please. So again, what I was saying when I was in the medical school, a definition and diagnosis of myeloma, an average survival was 2.5 to 3 years. But now, as you can see, the survival has improved over the decades. And now it is not unusual. As I'm saying, 15 to 20% of the patients were long-term survivors and maybe even cured. So next slide, please. And this improvement in the survival in patients with multiple myeloma has happened over the last several decades because of an explosion of research, new drugs, and advent of autologous stem cell transplantation in the 80s. And now we are in the era of cellular therapeutics with CAR-T or bispecific antibodies or intracellular signal transduction inhibitors. We call them as IBs, like small molecules. So there are many, many targeted therapy with monoclonal antibodies and proteasome inhibitors and medications like lenalidomide, pomalidomide. It made a paradigm change in the treatment and outcome in patients with multiple myeloma, with improving overall survival. Next slide, please. So this is a slide where I explain that the treatment of myeloma is like a lawn care. Well, whenever I say that, eyebrows are raised, but look it up, YouTube. I have this video, it explains. Let me explain. Say, for example, 6-8 years ago, someone did not have myeloma, and they have a fantastic green lawn. I'm going to compare the body with the backyard. And then when the myeloma is diagnosed, say, for example, the bone marrow has 30 to 40% malignant looking plasma cells, the backyard has equivalent 30 to 40% surface covered with wheat. So we go to the doctor, myeloma physician, and the physician gives usually a triple therapy these days, like lenalidomide, bortezomib, dexamethasone in cycles, 3-week cycles. and which is akin to using a weed killer to the backyard. After 4 to 6 such cycles, if we happen to do a bone marrow biopsy, I can tell you the bone marrow would look better in majority of our patients. This is called induction therapy or inducing remission therapy. So the backyard now looks better. Maybe few dandelions and weeds still standing, but it is far better than before. If we want a deeper remission, we go to the next phase called consolidation. And in a transplant eligible patient, we do a stem cell transplantation. So the previous oncologist has done a fantastic job, and I would call that a master gardener. But now we need a lawn renovation, a new grass seed, a grass sod. So what we do in that situation, in a transplant eligible patient, step 1, we collect stem cells from the blood. The stem cells are usually in the bone marrow. We have a means to get them out from the bone marrow by an injection treatment, and we can filter out the stem cells very simply from the blood and put them in a plastic bag and put it in the liquid nitrogen freezer to use later. Lawn care story, I just collected the grass seed from the backyard, put it in my garage. Now the real transplant. We do a high-dose chemotherapy, consolidation, that will not only clean all the residual myeloma cells in the bone marrow, but it will clean the old but normal cells to make space for the new stem cells to grow. And the next day, we take out that stem cell out from the freezer, thaw it, and put it back through the line, just like a blood transfusion. And the stem cells will go and take foothold in the nicely cleaned bone marrow. And it will take around 2 weeks for the stem cells to grow. During that 2 weeks, usually patients are in the hospital or very, very closely monitored. And after 2 weeks, the bone marrow will be repopulated with healthy cells, hopefully without the malignant plasma cells. So what we just did to the lawn, we collected the grass seed, we nuked the backyard, hoping all the dandelions are gone, including some of the roots are gone, but the green grass is also gone. Well, don't worry. We reseeded the backyard with new grass seeds, and it takes 2 weeks to grow. Now we have a fantastic bone marrow with deep remission and a nice backyard. That's the consolidation. Now, if we do not do the transplantation, we can intensify the induction or continue the induction for a deeper remission, but no lawn can be maintained without a strong maintenance program. So after that, we need a maintenance so the cancer does not return. And that's why I call it stages of myeloma treatment, where the tumor burden goes down, 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 and we continue the treatment through induction, consolidation, aka stem cell transplantation or lawn renovation, followed by a maintenance therapy. Next slide, please. And by doing that, what is our goal? Our real goal is cure. And that's my dream. Maybe during my lifetime, I'll be able to see increasing number of the patients getting more and cure. But to get there, we try to get to something called minimal residual disease or MRD negative status. The MRD negative can be identified by a multi-parametric flow cytometry, which we have in our Methodist hospital, or we can send it out for next gene sequencing, which actually can identify 1 in a million cancer cells, NGS. If somebody is MRD negative, clearly closer to maintaining that for longer duration, we call it prolonging the progression-free survival or PFS. Next slide, please. So the question is, how do you use all these drugs or medications that we have now at our disposal? The questions are, do we use 2 drugs, 3 drugs, or 4 drugs? Which 3 drugs? And which is the 4th drug? Roll-up transplant, maintenance. And the big question that I asked almost every day is, somebody who is in remission, is on maintenance, how long do we continue? And are we close to the cure? Next slide, please. So this is an elegant study by Swag, which compared a 3-drug with 2-drug. The standard 3-drug with lenalidomide, bortezomib, and dexamethasone, called RVD, compared to Len-Dex only. And you can see from these survival curves that 3 drug was better than 2 drugs. So in majority of my patients, if someone can tolerate 3 drugs, we usually use a triplet. That is the standard of care in 2021 for newly diagnosed patient with multiple myeloma. Next slide, please. So then comes the targeted therapy, the monoclonal antibody, our 4th drug. So myeloma cells or any other cancer cells, they have surface molecules, and one of the surface molecule in the plasma cell is called CD38. And in CD38 directed antibody, daratumumab, isatuximab, those are the antibodies. When given, they will go straight to the myeloma cells and invite the rest of the immune cells to kill the cancer cells. So really, daratumumab and the isatuximab and elotuzumab, these type of monoclonal antibodies have shown remarkable response in patients with relapsed refractory myeloma, and now they are being used upfront as well. Next slide, please. So this was the Maya trial where daratumumab was added to lenalidomide, and it's called DRD compared to a doublet RD. Now remember, this one was used in patients who were transplant ineligible. That means we're not planning to take them to the transplant. Next slide, please. And one can show that adding daratumumab to the Revlimid and the dexamethasone, it improves the median progression-free survival. But on the right side in the table, you can see even the responses, the deeper responses with complete and stringent are better on the daratumumab group. So it's perfectly all right to consider adding DARA-RD in a newly diagnosed myeloma when you're not thinking of taking to the transplant. Next slide, please. So the question now is, how about patients that are transplant eligible? Now there are quads beyond the triplet. This is a trial called Griffin trial, which I participated when I was in Kansas. And presently we have given some updates where data was added to the backbone of RVD, which I've shown you, which is probably one of the standard of care triplets for newly diagnosed myeloma. And these patients, after the DARA-RVD versus RVD, were transplanted, followed by consolidation with few more cycles of DARA-RVD or RVD, and then the maintenance. The maintenance was either DARA with lenalidomide or lenalidomide by itself. Next slide, please. Now, this is a very new trial, so we are estimating its responses right now, but the overall survival or the progression-free survival data, we may have to wait for a few years to get that data. But whatever we have now, we can show that the depth of response at every step after the completion of the induction, post-transplantation, post-consolidation, it continues to fare better in the DARA-RVD compared to the RVD. However, DARA-RVD is not approved as of yet. Now, DARA with other combinations like VMP and other things have been used in Europe quite often. So DARA has been used upfront, but just wanted to let you know that Griffin is not ready for an FDA approval yet. Next slide, please. So the other question that we get asked is how long to continue that treatment if somebody is in remission. So this was a trial called FIRST trial, where there were 3 groups of patients where the chemo in this particular one is Revlimid and dexamethasone, which usually we do not do these days, we do triplet, but you can get the message out of it. Either we do it continuously or we do a predefined like 18 cycles or 18 months and or MPT. Now in United States, we do not use MPT often. Next slide, please. And here you can see that continuous treatment actually improves your chance of remaining in remission, progression-free, compared to stopping the treatment. So if somebody is not a transplant eligible patient and wants to continue, what I would do, I would VRD for 8 to 10 cycles and then once they are in very good remission or complete remission, I probably will drop some of the triplets and continue the treatment indefinitely until the disease either progresses or there is some side effects emerging. Next slide, please. So with all these advances, is autologous transplantation still valid? The answer is yes. Next slide, please. Whenever there are new drugs coming out, we always try to compare that with autologous transplant. And every time we tried that, the progression-free survival shows the auto transplant is better than continuing chemotherapy. So again, I'm re-emphasizing in a transplant eligible patient, I would recommend a stem cell transplantation. Now, if the patient is not transplant eligible because of comorbidities, ages, and other things, then it's perfectly all right to use all the novel drugs. This particular trial was from Europe that had CyBOR-D followed by transplant, then VMP, continuous versus transplant and maintenance. Next slide, please. The summary of this is the progression-free survival was better in the transplant, the remissions were better, and the best part is it was good for both standard risk and high risk genetics, which I will be touching upon a little later in my slides. Next slide, please. So the summary of this is upfront transplant significantly prolongs progression-free survival. You know, someone may say overall survival advantage. We have not seen that in this trial yet. And it does improve the response. And we would recommend in younger fit patients consideration of the stem cell transplantation as a consolidation, as a lawn renovation after the initial induction. Next slide, please. So the other question is, my doctor told me my myeloma is in good remission. Can I delay that transplant? And that was answered by this next trial, please. Next slide. So this was, next slide, please. This is a French and US combined. The French part is already completed and published. The DFCI, the US part, has already collected the data. Here, patients were randomized into two groups, RVD, stem cell collection, either transplant or just few more RVD, and then LEN maintenance. So one group got transplant upfront, the other is later in case the disease relapses. Next slide, please. Here, the message is again clear. Patients who got upfront transplant, their progression-free survival was better. Their MRD negativity was better. Next slide, please. So the second analysis demonstrated that transplant is associated with the mortality was in the range of only 1%. So it is very well tolerated, and it's associated with improved progression-free survival. And overall survival is difficult to draw conclusions because many patients actually went into second time transplant, and then we need longer survival, and new drugs are coming. So even in the era of the new drugs, transplantation remains the standard of care. Again, I have to use the phrase in younger, fit, transplant eligible patient. Younger does not mean chronological age. I've transplanted age 81, but those people are really fit, like a cross-country runner would beat me any day. Next slide, please. So this is, next slide, please. This is talking about the maintenance, and which I already stated, unless we do the maintenance, there is always a risk of the disease coming back. And lenalidomide maintenance now is a long-term, shows every year we look back, patients who are on len maintenance, the overall survival and the myeloma risk is far less if somebody is on maintenance compared to non-maintenance. Now, of course, maintenance is tricky. We need to monitor for the low blood counts. There is a risk of blood clots. So patients should be on some form of prophylaxis with aspirin or a blood thinner. And there is a risk, something called second primary malignancy, other cancers. The incidence of that is around 4 to 6%. Now, the absolute risk means 95 to 96% chance that you're not going to get a second cancer, but 4 to 6% may, and majority of them are actually in the bone marrow. So my patients who are on maintenance, I do monitor their disease MRD status and also for the second malignancies almost annually or every other year. So if you are vigilant, then those risks could be abrogated. Next slide, please. So I touched upon the risk of the myeloma. So there are genes, chromosomes, by doing either a FISH or cytogenetics, we can classify them between the standard risk or high risk. Among the high risk, deletion 17p, p53, 414, 1416, translocate. These are the high risk genes inside the plasma cells. Now, they are not in the body. They are not being transferred from family to family in the generations. They are only in the cancer cells. Think of these as the roots of those dandelions. And hopefully by the treatment, not only the dandelion will die, maybe the roots will die as well. Next slide, please. So based on the risk, it has been shown that if somebody has a high risk, proteasome inhibitors and nowadays monoclonal antibodies sometimes actually helpful in choosing a treatment both in induction and maintenance and consolidation. So this is a paper from Emory where actually instead of just a single agent lenalidomide maintenance, they used bortezomib lendex maintenance and showed a fantastic 3-year above 90% survival even in patients with deletion 17p or high risk patients. So in my practice, if somebody has a high risk genetics, I would recommend not only just a lenalidomide maintenance, but also a bortezomib combination maintenance. So maintenance is something little more aggressive in high risk patients because the relapse risk is high. Next slide, please. So another question is, how long do we continue the maintenance? Right now, the recommendation, and I'm a part of the ASBMT myeloma guidelines committee, we say as long as the disease does not progress or if there is any untoward side effect, patients should be on indefinite lenalidomide maintenance. But some of my patients are MRD negative, no sign of any myeloma. Do they really need maintenance? We do not know that answer, but people have been trying to abbreviate the length of the maintenance. And this particular trial, again, we were part of it. Next slide, please. Here, initially, the patients were treated with Lendera maintenance. And if somebody is MRD negative after 2 years, they have been randomized to either continue the maintenance or stop. Now, of course, we do not have the data yet, but the message is if you are MRD negative and a persistent MRD negative, not just one-time snapshot MRD negative, then there's a possibility that we may stop the maintenance and monitor you like a hawk. Vigilance. But this answer is not there out yet. Next slide, please. So this is a very visual slide. It basically shows deeper the remission, longer the progression-free survival. So my goal is to get to not only complete remission, but stringent complete remission and eventually MRD negativity status. My last slide, I think. This is my most favorite slide. This is called a relative survival ratio. What is relative survival ratio? Just to give you an example, according to the age, sex, ethnicity, if, say, for example, I'm in upper 50 and I'm supposed to live for 30 more years based on my characteristics. And if I live up to another 30 years, then my relative survival ratio is 1. Okay, so that's the population survival ratio. When a patient is diagnosed with myeloma, as I told you, when I first got into my medical school, 2.5 to 3 years, patient would be alive. So the relative ratio right away at that time was 0.1. But then we advanced. We identified lenalidomide, proteasome inhibitors. We did transplant and maintenance. And as we achieved complete remission, stringent complete remission, more and more patients are getting it, they're living longer. The median survival is going from 3 years to 6 years to 8 years, gradually increasing. And then the maintenance and the relative ratio is now with the transplant, and this data is from Arkansas, is almost approaching the relative ratio of age and sex matched population. This is the reason why I do what I do every year. This is the reason what I did for 19 years in Kansas. And this is the dream that I brought here in Houston, so that with everybody's support, I can push the envelope with clinical trials. We opened already 8 clinical trials. 3 of them are myeloma. Hopefully by end of fall, we'll be rolling it out for our patients in this chapter. And with your blessings and with your support, hopefully one day we can say majority of the patients of myeloma would be cured. Next slide, please. And that's my summary. Right now, 15% patients of myeloma are cured. And my goal, my dream, maybe we can go higher. And if somebody is transplant eligible, refer to the transplant. And risk stratification, personalized medicines, immunotherapy that Dr. Abnor would be discussing holds a promise for future. Next slide, please. And this is where we were. This is where we are going, from chromosome to genes to future. And last one. And thank you, all of you, for welcoming me back to Houston. And with your blessings and support, hopefully I'll be able to do something good for the community.
Sid, that was fantastic. Can we go back to this last slide of Sid's presentation? That is a fantastic slide. When I started in the early 2000s, I would go out and visit support groups, and I'd have an index card where I used to use for studying in college. And I flipped it over before I went on my meeting. It said thalidomide, and I said, oh my goodness, I'm in the wrong world. This isn't what it's supposed to be. And now what I've seen happen over these years, these 18, 20 years, the future is awesome. I don't even know what kind of words to use, but Sid, what a fantastic presentation. Thank you. You covered a lot of topics for people, and I appreciate that.
And I thank Dr. Abnor and others. I saw that there were a lot of questions coming while I was speaking, and Dr. Abnor and others were answering. So really, thank you for that.
Well, one thing that came up that they answered, let's see, dexamethasone. Is it feasible to eliminate dexamethasone from some treatments? Rafat said dexamethasone is important in the first few months of treatment. And I want you to, can you expand upon that a little bit, Rafat?
Yes, of course. Of course. Oh, sure.
I mean, so there are actually clinical trial to show that continuation of steroid actually reduce the benefit of the regimen. So when somebody have a lot of myeloma, a lot of side effect related to the myeloma, I think dexamethasone can be helpful as part of the induction treatment, the first 3 months of treatment. But after that, there's really no clear evidence that it's very important. I mean, I think we have, if you're continuing therapy, for example, with Revlimid Dex forever, it's actually inferior to that if you just continue Revlimid alone. So I think it's just initially probably will be important to help with side effect and things like that. But we sort of went to this dexamethasone forever, and I don't think it's the right approach.
I totally 100% in support. Usually also the dose of the dex, which in younger people who can tolerate 40 milligrams once a week, first of all, we don't do high dose dex. That is out. We do low dose dex. Yeah. Even 40 milligrams once a week could be a lot for someone who is frail and elderly. So we definitely decrease the dose to 20 milligrams, and we would not use for more than 3 to 4 cycles. And after the maintenance, just single agent len maintenance for high risk patients, len plus bortezomib, and you can drop the dex right away. So lowering the dex and giving the dex in a way so the quality of life is kept intact is the most important thing.
Rafat, you said you wanted to answer that question. It just popped up. Go ahead.
So there was a question about somebody who had a stem cell transplant in 2006. It was diagnosed in 2006, stem cell transplant in 2007. They collected enough stem cells. They're still around. So yes, the answer is that those stem cells are still good, and they will be good as long as they are really in controlled environment, monitored 24/7. The temperature doesn't go below a certain level. So we have data from Hal Braxmeyer here, who looked at cord blood he stored 30 years ago, and then when he thawed the cord blood, the cells still were very active, producing white cells, red blood cells, and platelet. So as long as the patient is alive, the stem cells should be stored.
That is correct. And then we also check the stem cells viability before infusion. So just there's a double check and making sure, and majority of the cells, they maintain.
Okay, Sid, you want to talk about the COVID vaccination, as it reflects to, or as it is part of the myeloma journey today?
So for some reason, I cannot see the questions. I don't know where I click. QA IMF.
QA.
I think it was, how do you know that the vaccine is working?
Right. So this is a question that actually being addressed by many trials that we are doing, if the vaccines are working or not. So one of the things that we did in Kansas City is we tested the antibodies, the anti-spike antibodies. And the vaccine response is definitely not as high as in healthy, no other comorbidity persons. But we still recommend vaccination because we do see antibody presence and persistence, especially after 2 and now with the booster vaccinations. So it may not be very high in patients who are immunocompromised, but I would still recommend that something is giving some protection, and we must continue the vaccine effort, including the boosters in our immunocompromised population.
Yeah, I mean, I agree. Yeah, we've been following the antibody against the spike protein, and some patients who receive certain treatment or a very intensive treatment with anti-CD38 antibodies are losing the antibody response. So we try to adjust the treatment, revaccinate the patients. I think I agree that every patient should be vaccinated, and when it's time to get the booster, they should get the booster. Sometimes what I do is I recommend after the vaccine is that, for a couple of weeks, we don't use very high dose steroids or an anti-CD38 antibody to try to preserve the immune response.
Okay. Anne, how are you dealing with this in your clinic with respect to the shots and so forth?
We are recommending the COVID vaccine, obviously, to all our patients, and also the booster shot as well. And as was mentioned, we are recommending not using or avoiding dexamethasone for a short time afterwards. But yes, we are recommending, but we're seeing the same thing. Some patients who we are testing for spike antibodies are not showing signs of detectable COVID antibodies.
Great. We do have a question there. It says, when the stem cell transplant is complete, how do I interact with those who hadn't taken their vaccines?
You want to take that one?
Don't interact.
Yeah, don't
Stay away
interact.
from them.
If you want to interact, social distancing. I ask my patients to wear a mask and don't sit down and eat with somebody who's not vaccinated, because the longer you are sitting close to somebody who's not vaccinated, the more likely you're gonna, get the virus. And the question is, are you gonna able to handle it, or you're gonna get flu-like symptoms, or you're gonna end up in the ICU on the event? I wouldn't.
So the person who wants to interact must be a family, friend, colleague who cares for the post-stem cell transplant patient. And if that's true, then they should be vaccinated. They should go out and get vaccine to interact with the loved one. That's what I would recommend.
Well, considering that what we just talked about, this is kind of a general question. I think we should go back to the slides. What do you think if I've been diagnosed with smoldering myeloma, but have the TP53 17p deletion?
Okay, so this is a very interesting question. So the smoldering myeloma field is moving fast. I would say 4 or 5 years ago, we all recommended patients with smoldering myeloma should be followed closely, but they do not necessarily need treatment. Nowadays, we are identifying those patients with smoldering myeloma that tend to be high risk, meaning statistically 80% of them would turn into myeloma over the next 2 years. They might benefit from early initiation of lenalidomide-based treatment. And who are those? Majority of the trials have corroborated the clinical criteria called 20-20. That means the ratio more than 20, like an involved over uninvolved. the M protein more than 2 gram per deciliter, and bone marrow plasma cell more than 20%. That had been included in majority of the trials to classify as high-risk myeloma, and intervention in that particular group has shown clearly survival advantage, at least in the PETHEMA Spanish trial. And we had something called ASCENT trial that we are running, actually taking them even to the stem cell mobilization and collection. P53 definitely puts a high risk, not only P53, 414, 14, 16, they are considered to be high risk. And if they are in the 20 to 20 category, they should be talking to their myeloma specialist for early institution of therapy. But if they are not high risk, but they are P53, but not by the markers, then they should be monitored very, very carefully. So for example, somebody has 12% plasma cells, 17P, and the M spike is 0.5. I would not initiate treatment just because somebody is 17P, but I would monitor them very, very vigilantly. This is almost like CLL patients, as you know, chronic lymphocytic leukemia patients, stage 1, if they're 17P, I would not treat them, but I would monitor them very carefully because they will spill to the symptomatic disease any day.
Yeah, I second that. I mean, I think it's very important not to treat the genetic abnormality, especially in the story was the 17p deletion is really not very well understood, because when you have deletion of the long arm of chromosome 17, that is not the problem. It's the problem on the other chromosome 17, because we always have two chromosome 1, 2 chromosome 2, 2 chromosome 17. If you lost the long arm of one of the chromosome 17, that's not the problem. It's the problem what's on the other chromosome 17. Is it a mutated TP53 that lead to your problem? And not everybody who has 17p deletion is high risk, so you need, so I think clinical monitoring carefully, like you heard, is very important, but don't just panic that you have a 17p deletion. I think close monitoring is very important.
Yeah, treat the patient, but not a result on a piece of paper.
Oh, I agree with that a lot. Anne, would you like to add anything to what the doctors have been speaking about before we go on to the next segment?
No, I mean, we also do not treat smoldering myeloma, that's 17p. We just watch them very closely. Same kind of procedures.
Okay. Any gentlemen, would you like to add anything else to that?
I have a quick question for Dr.
Sure.
Abnor, and in your clinical practice, not in the clinical trial, have you started treating 20 to 20 smoldering myeloma patients, or are still waiting for more data?
Well, I actually, I don't believe in treatment that is intended to push the count down the road. So if you look at Revlimid in, for example, as a single agent or with steroid in patient with high risk smoldering myeloma, really, I mean, what you're doing is you're delaying progression. I believe if you want to treat, you should mean it and you should cure the disease. So I think the International Myeloma Foundation was a leader of the ASCENT trial. We finished accruing on the ASCENT trial. We will find out if an induction consolidation and a maintenance 2-year therapy is very important or not. And if this trial pan out, then I would say to my smoldering myeloma, listen, we're going to be aggressive, but we're going to cure you. We're going to get you into MRD negative that is sustained. But outside a clinical trial that meant to cure, I would just be hesitant, because I mean, I think it's not a walk in the park to be on therapy for a long time, because you've been seeing myeloma for more than a couple decades, and they can smolder for a long time. And when you put them on therapy, the cost, the quality of life is not the same, is it? And so I like an open-ended treatment. I don't believe in treatment forever. So I would like to see more a clinical trial to prove to me that intervention is meaningful.
Fantastic.
Saying that.
All right. Well, that was the last question for the moment. I would like to go into our next segment. Thank you, the panelists, and Anne and Sid. And Sid, thank you for your chat. The next speaker, we go back a couple of months, and he's going to be speaking about relapse therapy and clinical trials. Dr. Avenar has been answering some questions here throughout the process, and I have great respect for him. And without further ado, I'd like to introduce Dr. Rafat Avenar. Indiana University School of Medicine. Take it away, Rafat.
Thank you, Kelly. It's good to see you again virtually. Hopefully we'll see you soon. Today it's raining in Indianapolis, so I couldn't, really do anything more exciting. So it's good to be with you today. And what a nice introduction about multiple myeloma by Dr. Ganguly. Wonderful job. So I'm going to pick up the part where patient now start relapsing. And so the question, what do we do here? How do I treat patient with relapsed multiple myeloma? If you can give me the second slide, please. Next slide. So when should we treat patient with relapsed multiple myeloma? Should we treat them when they have biochemical relapse? What does that mean? Their myeloma proteins start rising. They went down to 0 or 0.2, and now it's 0.5 or 1. Should we treat them? Or when the involved light chains start rising, somebody who has a lambda light chain normalize, and now instead of being normal is 5-time upper limit of normal. Do we treat them? Or do we treat when we have clinical relapse? What does that mean? About the CRAB criteria you heard about for diagnosing myeloma. Patients start becoming anemic or had kidney failure, very high calcium, new bone disease, or patient who developing now what we call extramedullary disease or plasmacytoma, myeloma growing outside the bone. When do we treat? Next slide, please. We don't know. But we can speculate. Most approved treatment is basically, in relapsed multiple myeloma, any trial is really based on biochemical relapse. But there are some observations support better outcome when treating at biochemical relapse. For example, Mayo Clinic did a study that's showing if you treat at biochemical relapse, the time without progression is much higher than if you treat at time of clinical relapse. Patient on the median have 125 months versus 81 months. So maybe treating at biochemical relapse is a good thing. Next slide. But the problem is, 25% of biochemical relapse patients will have a smoldering course, like a smoldering myeloma, and they don't progress for 2 years. So we're treating, 4 patients, one of them may not need to be treated. So that's the con, I think. The pros is that when you start having your biochemical relapse in a relapse setting, refractory disease, actually the patient will start having symptoms in 5 to 6 months. So you don't want to have a patient with biochemical relapse, you're sitting on them, and then 6 months later, they have a broken vertebra in the back. That's not a good thing. And I always say that if you don't get it right at first relapse, you may not get it right at subsequent relapses. So next slide, please. So if you look at the duration of response with each relapse, if you look at first, second, third, fourth, fifth, sixth, the duration of response is shorter. Myeloma become more aggressive, harder to treat, and the patients will enjoy only a shorter duration of response. Next slide, please. So next, please. So I think, the things we need to remember about multiple myeloma is that each myeloma patient, especially with each relapse, they don't have the same kind of myeloma cells. They have a family of myeloma cells. We call that clonal heterogeneity, which means that each time you're treating myeloma, you're treating different kind of myeloma in each patient. So you have one part of the cell, some cells will respond to drug A, but not drug B. Other cells will respond to drug B, but not drug A. And so this wide heterogeneity within each patient really require a combination therapy. You cannot expect a relapsed patient to benefit from one drug. We used to say, well, sequencing versus, treating them right. And I showed you, already that each relapse, the duration of response is less. So when you have a relapsed patient and you say 30% of the patient respond to drug A, do I just want to use drug A and only 30% of the patient respond to it? I think combination therapy at relapse makes sense. Next. So basically, in English, clonal heterogeneity is that myeloma cells in each patient is like a family of odds and aggressive members. The longer this family sticks around, the odder and more aggressive they become. So family therapy is not going to work. You need to treat them early. You need combination therapy. Next, please. So factor that influence the choice at the time of relapse, disease related, regimen related, patient related. So what are they? Next, please. So if you look at disease related factor, how are they relapsing? Do they relapse with, broken bone, high calcium, renal failure? Do they have a new plasmacytoma? Do they have higher risk cytogenetics, extramedullary disease, plasma cell leukemia? All that stuff can influence, obviously, the choice. If you have a high risk disease, plasma cell leukemia, makes sense to include a class of drug we call PI, proteasome inhibitor, Velcade, Kyprolis, and the like. Next, please. Then the regimen-related factor. What was the previous treatment and dose, duration of response to it, the side effect to it, and the depth and duration of previous transplant? So if you have somebody who transplanted in 2006 and have done very well, and now they're relapsing, in 2021, that's a good response to transplant. I would consider it again. If they had a regimen, they had no side effect to it, and now they relapse 5 years later, I may consider the same regimen if, they don't have any side effect. If you have neuropathy, you want to avoid drug that cause neuropathy. If you have heart failure, you avoid drug that cause heart failure. So the regimen related factor, I think, is very important. Next. And patient related factor. I mean, obviously, we can't be very aggressive with patient who's not that strong. But if you have somebody who has a good performance status and had a transplant 15 years ago and doing well, we can do it again if they're in good shape. What else going on with the patient? Do they have diabetes? Do they have heart failure? Do they have neuropathy? That influences the regimen we choose. And obviously transplant eligibility can be also a factor. And I think the last two things are very important. Patient preference. I mean, the patient said, listen, I actually don't have time to come to the clinic to get an infusion 2 days a week. I want a regimen that it's easier for me, an oral regimen and things like that. We should honor that. And I think there are combinations that can be that way. And obviously, we still enjoy in America that, we can give any drugs we want, but that may become a little difficult. Cost and socioeconomics may play a role in choosing the regimen for relapsed patient. Next, please. So this is currently available anti-myeloma agents. So once you relapse, it's not a bad news, okay? Look at this. I mean, I think, Dr. Ganguly and, can attest to this. When we started doing myeloma therapy, we had melphalan prednisone. And then, we start having the transplant, and then we had the Revlimid, and, after thalidomide, and then we had the Velcade and 2 PIs after that. And then we have all these new drugs, the anti-CD38 drugs, the anti-CS1, the anti-BCMA, the CAR T cells, and then the selinexor. So a lot of options for the patients. We have a new alkylating agent, melphalan, and then don't ever forget venetoclax for patients who have translocation 11-14. They actually benefit from this drug, and they can be used in combination. So it's really a very good place to be today in myeloma therapy when you have, I don't know how many here, 14, 15 different options, drugs available that are FDA approved for myeloma. When we started doing myeloma treatment, we had 0 drug approved for multiple myeloma. Next, please. So how does your oncologist decide how to treat you for multiple myeloma? This is it's like you're going to what? Cheesecake Factory, and you're getting a menu that is about, encyclopedia of options. There's a lot of options. So they don't look at this kind of menu. Next slide. They look at what we call the NCCN guideline. So that's the National Comprehensive Cancer Network. And this is a, group of myeloma experts from the center sit down and say, okay, this regimen is great. Let's use it. RVD, we use it for every patient. And then we call that, category 1. if you really don't like the regimen, you think is the data is not that strong, you make it category 2. Well, these are category 1, most of these patients. If you look at, those regimen, look how many options available to them patient. It's great news that we have options. The bad news is that how your doctor, your doctor may get confused, So I think studying the patient, studying the genetic of the disease, the presentation of the disease will help you choose one of these options. Next, please. So if you look at easier sort of guideline is our colleagues at Mayo Clinic comes up with these called the M-SMART, first relapse off study. What do you do? If somebody was on maintenance Revlimid, they recommend you try a different image. So for example, if somebody has relapse with, and fit, you can consider Kyprolis or carfilzomib with Pomalyst or pomalidomide, or you can consider daratumumab with Velcade. If somebody has an indolent relapse or frail patients, maybe you can consider an oral regimens like Ixazomib, Ninlaro with Revlimid, or something else. If you are off therapy and maintain and you relapse, you can do KRD is a good regimen, or you can do daratumumab, Revlimid, dexamethasone. So this kind of approach try to sort of reduce the confusion that the NCCN guidelines provide. Next, please. And this is for second or later relapse, and you can see there's circulating some of the drugs that use initially, but probably the highlight of these, regimen is that a monoclonal antibody and anti-CD38 is considered there, and obviously one will need to also consider BCMA antibodies eventually in the relapse setting, and we'll talk about that in a minute. Next, please. So combination is really better. So this is the first trial in relapse setting that looked at Revlimid Dex, because that's what people used 15 years ago or 10 years ago. When you relapse, you get on Revlimid and dexamethasone. You get Revlimid 25 milligram daily for 21 days and Dex 40 milligram once a week. So the question was, can adding a monoclonal antibody, you saw the picture of how the antibody worked, this daratumumab in this case, can it work? So this is a clinical trials where half the patient get Dara Revlimid and the other half just get Revlimid. So the question is, what is the sort of duration of response, the overall survival, and things like that? So next slide, please. So what they showed in this trial, next, please, is that something we call progression-free survival, which is really time without needing to worry about myeloma or side effect related to myeloma. It improves significantly when you add daratumumab. At 30 months, there are 58% of the patients were without progression, and if you use Revlimid alone with Dex, it was 35%. So clearly a 56% reduction of the risk of progression by adding daratumumab. So that proved that 3-drug regimen with daratumumab in the relapse setting is very effective. Next, please. And they looked at, whether you actually use it, somebody who just relapsed quickly from last line of therapy or more than 12 months, and the benefit was the same. Because sometimes you say, if you relapse too quickly, you have a very bad myeloma. You may not have the same benefit from new treatment. And the answer is actually no, you still get benefit. Look at the patient who relapsed in the first year after their initial treatment. 70% stayed without progression if they get daratumumab versus with Revlimid versus Revlimid alone. So I think for any relapse, a monoclonal antibody with an IMiD is a very good thing. Next, please. And obviously now we have another monoclonal antibody, isatuximab, and that has been, this drug has also been tested with an IMiD, pomalidomide in this setting, and also been tested with carfilzomib, Kyprolis, and it clearly showed that adding the monoclonal antibody to IMiDs, POM, adding the monoclonal antibody to Kyprolis, the K, is superior in terms of progression-free survival, and that's what led to FDA approval of these combinations. Next, please. So, anti-myeloma antibodies are interesting and evolving. So antibodies like daratumumab and isatuximab are the naked antibody. They just bind to the myeloma cells and then bring the immune system, the complement and the cytotoxic lymphocyte to help eradicate the myeloma. But nowadays, I think people are trying to be more fancy. I mean, can we make an antibody more powerful by adding to it what we call a conjugate, such as in BCMA, methadone. It's an alkylating agent. It's a chemotherapy. Once this antibody binds to the myeloma cells, this toxin goes inside the myeloma cells and blow it up. And then we have these called T-cell bispecific antibody. So when we give the naked antibody, we ask the immune system of the patient to work. And sometimes it's kind of lazy, the antibody binding to the myeloma and the immune cells go by and it just doesn't care. Well, can you make that antibody more specific? So one part will bind to the myeloma and the other part will bind to the immune cells of the patient. So when the immune cells go by and get attracted to that receptor, the T-cell antigen. And so these are the bispecific antibody, and there's like 5, 6 of them, and it's just amazing how well they're working. And then obviously, you get the CAR T cells that are amazing too. So we'll talk about that in a second. Next slide, please. So these are sort of comparison of the CAR T cells, the bispecific antibody, and the antibody conjugate. So CAR T cells, you all heard about it, is basically what we do is we take your T cells, which are the immune cells. Their job is to fight viruses, to fight foreign cells. And what we take these T cells from you and we send them to a manufacturing facility where they make these T cells recognize myeloma and kill myeloma. So that's what we call it, chimeric antigen receptor T cells or CAR T cells. So it's amazing. I mean, we have several CAR T cells now. One of them already approved, the Abicma, and then probably one will be approved in next month, in November maybe. And basically what they do is, they go in and they kill the myeloma cells and they get patients free of myeloma, MRD negative. So that's great. However, most of the trials showing a progression-free survival of about 1 year. The science of CAR T cells is amazing. The response is amazing. What's not amazing is the duration of response. Why? Why is myeloma cells are still resistant and they a year later come back? You don't want to give somebody $450,000 drug that only worked for a year. So maybe we need to give another dose of CAR T cells or something else, or do some maintenance for a while after the transplant, or make all myeloma cells visible to the CAR T cells. Those strategies are being tested. We actually have, some clinical trials trying to start for that. So the problem with CAR T cells is that, you have to have the T cells, you have to manufacture them, you have to keep the disease under control until the CAR T cells are available. And the last problem is the duration of response. On the other hand, the bispecific antibodies off the shelf, you can order it from the pharmacy. It's going to be used, and we don't have anyone approved yet, but I think I would expect one will be approved in the first quarter of next year. Those are great because, you don't have to worry about manufacturing. You don't have to worry about bridging therapy while you're waiting for the CAR T cells to be ready. So you can give them right away, and they don't have the same degree of side effect of CAR T cells. CAR T cells have to be given by experienced physician at an experienced facility, because you can get something called cytokine release syndrome. You can get neurotoxicity that, you have to know how to manage it. If you don't know, the patient may not do well. So, but the incidence with bispecific is less. So advantage of bispecific, off the shelf, less toxicity, You can keep using it until you get your patient into a lasting MRD negative, so the patient do well. And then the antibody conjugate, again, is off the shelf, it's available. We have one already approved, no CRS, no hospitalization, outpatient therapy. The ocular issues, we'll talk about it in a second. Next slide, please. So why BCMA? Why all the CAR T cells, the bispecific, the conjugated antibody, like the BCMA as a target? Is actually, it's not just being present on the surface of myeloma cells and the pre-myeloma cells, but also BCMA does control the proliferation of these cells, make them grow. So if you engage it, turn it off, these cells will die. So there's multiple mechanisms by which myeloma cells die when you use a BCMA antibody. So it's very attractive. Next, please. So the drug that's available and approved by the FDA, now we've been using it for a while, belantamab mafodotin. So basically, if you look at the box here, what you're seeing is that the antibody is binding to the myeloma cells. The mafodotin, which is the alkylating agents, goes inside the myeloma cells and blow it up. You use the immune system also to kill the myeloma cells. So really a lot of different players playing a role in sort of destroying the myeloma cells. So although it's a single agent drug, but it's really more than single agent drugs, probably coupled drugs and also using the immune system. So next, please. So in the first phase 1 study called DREAM1, and now we have actually up to DREAM6 trial ongoing, looking at the drug in combination. In single agent and highly refractory patient, the response rate was about 60%. There are a lot of, what we call stringent complete remission and complete remission, i.e. very deep response in this setting. So it was very exciting to see such a depth of response with a BCMA conjugate antibody Blenrep. Next, please. The issue that continue to be a problematic is the ocular toxicity. So we don't really understand it completely, but the outer layer of your cornea get damaged. So you get what we call keratopathy. So the lining of the of your cornea maybe get damaged. So for that reason, this drug is only giving when you have an eye exam within 2 weeks of prior to each treatment. And obviously, if you have a significant toxicity, you have to hold the drug, adjust the drug. But there are a lot of clinical trials looking at dose modification to try to improve the outcome. For example, in one of the DREAM trial, looking at, instead of giving the drug every 3 weeks, they're looking at every 6 weeks. So that may answer the question of the ocular toxicity. It's not to be minimized, and hopefully we can overcome it because I think it's a very active drug. Next, please. So there's another trial looking at new alkylating agents called Horizon. The trial looked at this drug called melphalan in combination with pomalidomide, presented with Dr. Paul Richardson. Next, please. So this is interesting because it's a lipophilic kind of drug. It goes inside the myeloma cells. Because of this, the myeloma cells have this very high level of this enzyme. It can break it down, release the chemotherapeutic agent within the cells, and lead to the destruction of the myeloma cells. So next, please. So it looks like it's effective in about a third of the patients and in all the patients. And it worked in patients who have had all kind of treatment prior to that. So it's a very interesting drug. Obviously, you have to watch your CBC, your white cells, red blood cells, and platelet. It may be suppressed and adjust the treatment accordingly, but it's another option available to patient. Next, please. So I think this is my last slide. I mean, what is the best therapy for relapsed patient? I mean, the thing about it is that need to remember that not all relapses are the same. I mean, so you have a biochemical indolent relapse, you have a symptomatic relapse. And I think we need to remember when patient relapse, they're relapsing with several clones of different characteristics. So I believe that combination therapy does provide better outcomes. And the good news is that, we have better drugs. We have more drugs available. We have better combinations. So I think is the, I always tell my patient that myeloma is not a death sentence. I mean, I think obviously I would love to say that we're going to cure you. And I think some of the early trials with 4-drug regimen hopefully will cure a large number of patients. Some of the drug we're using, for example, CAR T cells or bispecific antibody can be used as maintenance, can cure patients, but we have available options for patients when they relapse. And the optimal therapy is based on your needs. You need to discuss your options with your doctor. Say, why am I doing this? Can I do a different regimen? Because I think quality of life is very important. Being able to enjoy life is very important. So I think do not hesitate to ask for options, because as I showed you, based on the NCCN guidelines, there are many, many options for you when you relapse. So do not be afraid. Ask for options. And I think the most important thing in my mind is that when you have a relapse disease, try to get it right at the first relapse. Because when you start having multiple relapses, sometimes it's really hard to manage that. I think that's my last slide, Kelly, is it?
Yes, it is. And can we go back to the slide there? I love the optimal therapy is the one based on your needs.
Yes, sir.
Rafat, I remember you telling me that a long time ago, and I was very green to this world. And that was something that really stuck with me for a long time. And you displayed that in your slides and your talk today. The final one is we need to get it right at the first relapse. So as Dr. Abanar said, there are so many things going on, so many trials, so many new drugs, et cetera, coming out, that the outlook is better as a myeloma patient than it was even 10 years ago. So Rafat, thank you very much. That was a great talk. I noticed that we didn't have any questions. So what I'd like to do is go ahead and go on to Ann McNeil. And she's going to talk about how to manage myeloma symptoms and side effects. Ann has a lot of experience in this and a lot of acronyms after her name: registered nurse, MSN, APN. So I feel comfortable that she's going to lead us down that path of side effects and symptoms and help us get through it. So Ann, are you ready to take it away?
I'm ready, Kelly. Thank you so much for that. Thank you so much for that introduction. So again, we're going to just learning how to navigate your journey. Next slide. So there's several members that are needed for a successful journey. So you and your caregiver are on the center of this little picture here, and you have to understand the different roles of your healthcare team. So as you see here, you have your primary care provider, your subspecialist, which could be your cardiologist, your nephrologist, and so on. You have your general hematologist, oncologist, could be your local cancer specialist. And then you have your myeloma specialist that may be involved. And then you have your allied health staff, the medical assistants, and every other support person that will help take care of you. And of course, you have your family, your friends, and your personal support network. And you should understand how they can all help you out during this journey. Next slide. So as the physicians in the previous two presentations mentioned, there are many treatment options for you to consider. And if you look on the right-hand side, we do eventually come to a treatment decision. So how is that decision made? So it's based partly on your healthcare provider's clinical experience. It's also evidence-based. So data from research and clinical trials will help us come to a conclusion. But again, as Dr. Abanar just said, it's also your decision, your preference. There are many options and you have to be involved, you or your caregiver or both, be involved in the decision as to your treatment plan. And all of the drug classes are mentioned here with their common combinations, as we've mentioned before in the previous two presentations. Next slide. So be an empowered patient. I think that's very important. Participate in the discussions and the decisions. Asking for time to consider options, if that's appropriate, should be considered as well. I think understanding your options is very important, asking the right questions, and also on the outside, going to reliable sources of information. The key word here is reliable. So ask your healthcare team for the appropriate websites. Of course, myeloma.org is one of them, but you want to go to reliable sources of information. And please use caution considering stories of personal experiences. And these may be stories you read about online, in social media. In the past, people would chat in the waiting room. Every person's myeloma is different. So please, take that into consideration. Express your goals, your values, your preferences. Again, that shared decision-making is very important. Arriving at a decision together, you, your caregiver, your family, and your healthcare team. With all the options available for you now, we can make the right decision for treatment, whether it's frontline or first therapy or therapy at the relapse setting. Next slide. So communicating effectively with your whole healthcare team is very important. So on the left, being prepared, writing down your questions and concerns. You might say, well, I'll remember. I've had these 2 questions that I have to ask my physician or my nurse practitioner. I'll remember, but maybe you won't. So do write them down. Write them down, bring a little piece of paper with you, and make sure your questions get addressed. Also, please keep us up to date with your current medications and supplements. You may want to bring in everything or bring a list. And again, not just the prescribed medications. We do want to know what supplements or over-the-counter preparations or herbal things that you're taking. We do want to know. We do want to know about any medical or life changes since your last visit. And medical changes are important, but also life changes that aren't medical are important. Did you have a change in your living situation? Are you now living alone? Did you move? Do you have a financial situation that is of concern? Again, all of these things are important to us. Current symptoms. Has anything changed with how you feel? Please, we can't read your mind, so please let us know. And in the middle, right, speak up. Speak up. Tell us what's going on. Ask your important questions. Understand your treatment plan, okay? And the next steps. You might say, well, okay, I'm willing to do this treatment option. What's going to happen if this happens, if A happens, if B happens, okay? Have a list of who to contact and when. We should absolutely have your emergency contact information, your primary care doctor's information. I think it's important for us to have that information so we can all be part of your team. I think it's also really important to bring a caregiver for another set of ears, right? It's always important to have that extra set of ears and eyes that can hear and see what's been going on during that visit. I do understand with the recent pandemic that there were guidelines with who can come to the office, who couldn't. I think now most offices are allowing you to have one person come during your visit. So it is important to have that person come with you. And it's important when you leave the doctor's office, communicating with other members of your healthcare team, right? Whether it be the pharmacist, your primary care physician, all members of your healthcare team. Taking medications as directed. Very important because a lot of our medications are oral. They're called oral oncolytics. They're chemo or cancer drugs that are taken by pill or capsule form. We can't see you and watch you every day, so it's important to take those medications as directed. And of course, proper follow-up. I can't tell you how many patients I've had who have done extraordinarily well, especially after transplant. They feel great, they don't follow up, and it can definitely be a very challenging and problematic situation if they do relapse without having seen us in a number of months, if not years. So that's important for proper follow-up. Next slide, please. There should be some tools to help you discuss your treatment plan with your healthcare team. I know that the IMF does have a little treatment discussion tool that's available. I think that it's very important to take time to consider your preferences, your goals, your likes and dislikes before an appointment. Okay, so some of the important questions that you want to ask are what can I expect now? What is my expectation now with treatment, how I should feel from the myeloma perspective as well? What can I expect in the future? And definitely having these conversations at many steps along your journey, okay? Obviously at diagnosis, whenever your treatment stops working. Many of these treatments, especially in the relapse setting, are until there's evidence of disease progression or some unacceptable side effect that you're not willing to withstand. Whenever you start a new treatment, again, you're having these conversations about what to expect. Whenever there's a change in your life priorities, again, very important to talk to us about that. I mentioned maybe moving or having a death in the family. It's very important for us to know what's going on. And anytime, any question, nothing is too silly, nothing is too unimportant, nothing is too trivial for us to consider if it's important to you. So please have these discussions with us at every time. Next slide, please. So myeloma as a disease state and the treatments we give you both contribute to how you feel. And most of you in the audience can definitely say yes to that. Myeloma cells on the left-hand side of the slide, myeloma cells in excess can cause symptoms in and of itself. Calcium elevation can cause symptoms. Having kidney disease can cause symptoms, anemia, bone pain, fatigue, infection-related issues, and of course, there's a whole myriad of other symptoms. But the treatments that we give you for myeloma kill the myeloma cells, but also can cause a lot of symptoms. Myelosuppression, which means the drop in your blood counts. Peripheral neuropathy, that numbness or tingling or funny sensations in your hands and feet. Diarrhea, fatigue, deep vein thrombosis, the blood clots that can occur. Infection, okay? It could be shingles. It could be an upper respiratory infection like pneumonia. There are lots of symptoms that can occur just from the treatments we give you to make your disease under better control. And all of these contribute to how you feel. So it's the myeloma and the treatments we give you for myeloma. Hopefully we're getting your myeloma under control so some of those symptoms can be lessened. Next slide, please. So what happens if symptoms are not managed effectively? I think this is pretty straightforward. If you have poorly managed symptoms, this can lead to a variety of situations, right? Anxiety, depression. You can become isolated. You don't want to leave the house because you don't feel well. You don't want to be with your family because you don't feel well. It can lead to missed doses. Again, I mentioned a lot of chemo is given as an oral agent. It could lead to missed doses or even missed appointments where you're missing some of your injections or IV infusion related treatments. And of course, if you miss doses, you're going to have reduced treatment efficacy. Folks, drugs do not work unless you take them, right? Or unless you go to the office and get the drugs. They don't work if you're not taking them properly. And of course, all of this can lead to reduced quality of life. And I love what Dr. Avanar said in his previous presentation is we want to treat your myeloma, but we also want you to have an acceptable quality of life. Okay, so that's very important for all of us as your healthcare team. So discussing how you feel with us is important. And if you have to keep a symptom diary, that's great. I know a lot of you on clinical trials, that's almost mandated, right? So you keep this little symptom diary, but even if you're not on a clinical trial, jot down how you feel on a particular day. And we can also determine if how you feel is related to your treatment dosing. There are many options available that we can discuss with you, but we cannot help you if we don't know what's going on. So my favorite is the patient in the exam room who comes in with his wife or her husband and says, you know, when I ask how they feel, they say, I feel great. And then of course you have the caregiver looking around going, wait a minute, no, you don't feel great. Let's tell her how you feel. So we do have to, as the healthcare team, we have to listen to you, but we also like to listen to the caregiver because sometimes we get more information from them, right? Express your priorities. Definitely tell us what's going on. Fatigue is a common concern, but making the right treatment decision is higher priority for most. Okay, but we want to know how is fatigue affecting your quality of life? Is it an intermittent thing that you can handle, or is it an everyday thing that is severely impacting your quality of life? Please let us know this, okay? Sometimes just minor little things we can do with dose adjustments or scheduling changes can circumvent this feeling of profound fatigue. Next slide, please. Steroid side effects and management. And again, I think that most of you in the audience can probably give this lecture better than I can about steroids. We're all familiar with steroids. I think that in the beginning, when I first started working with myeloma and we were giving frontline treatment to patients, I would focus on the chemotherapy end of the drugs, whether it be Revlimid or Velcade or whatever it may be, right? And then I would say, and you're also going to get dexamethasone, and not really talking about the side effects of dexamethasone. And of course, most of the side effects that patients subsequently complained about were related to the steroid dosing. So I think it's important for your healthcare team to really talk to you and educate you and counsel you about these side effects. So what are they? On the left-hand side, lots of side effects, not just physical, but emotional, irritability, mood swings, depression, crying all of a sudden for no reason at all, right? Difficulty sleeping, a lot of insomnia, fatigue, that up and down. You feel great when you get steroids, and then a couple of days later, you might feel like a truck ran you over, right? Really bad fatigue. Increased risk of infections. Very important. These are immunosuppressive agents in and of themselves, okay? Heart disease, high blood pressure, muscle weakness, cramping. So it's a drug that can definitely have long-term effects on your muscles. I mentioned hypertension, water retention, holding on to fluid, having the swollen ankles and stuff like that, blurred vision, early onset of cataracts. You can feel flushed and have a lot of sweating, that red face, the cheeks appear red after you get dexamethasone. A lot of GI side effects, bloating, distension, acid reflux, ulcers, gas, hiccups. There could be weight gain, not just from the fluid retention, but from also the increased appetite, okay? Hair thinning, hair loss, skin rashes, skin thinning, easy bruisability. There's a lot of things that happen with your skin. Increase in blood sugar levels. All of the diabetics out there that had to be put on steroids know that their blood sugars were a little bit higher the day of and the day after, perhaps, when they're taking the steroid dosing. So again, if you are a diabetic, the person who manages your diabetes needs to know that you are diagnosed with myeloma, and you will be getting dosed with steroids as part of your treatment management. So how do we manage steroid side effects? There should be a consistent schedule. Some people have to take their steroids in the morning. They get that alertness, that hyperactivity kind of feeling right away. And then they get fatigued. And some people, there's a delay in that kind of side effect. So for some people, taking steroids at night is more beneficial to them. This is a personal thing, sort of a trial and error. You have to decide what is best for you. Always, please take your steroids with food. Don't take steroids on an empty stomach. Gastritis or that really horrible heartburn and really more serious side effects with your stomach can occur. So please take your steroids with food. You can use over-the-counter or prescription medications for stomach discomfort. Again, please let us know. Communicate with us. What's going on? Are you having stomach discomfort? Did you try some things over the counter? If they weren't helpful, we may have to intervene and prescribe something for you. And with certain dosing of steroids, typically the higher dose steroids, we do want to also concomitantly give you medications to prevent certain infections. Again, that's based on the steroid dosing. What's really important, folks, is that steroids help kill myeloma cells. They will help the myeloma cells commit suicide. So please do not stop or adjust these steroid doses on your own without discussing it with us. And again, both of the physicians who spoke today talked about not using steroids long-term, or reducing the dose after the initial induction therapy, or changing the schedule, perhaps. We do that as well, but please don't do it on your own. Please talk to us about that, okay? Next slide. Fatigue, depression, anxiety, okay? All can affect quality of life and all of your interpersonal relationships. And of course, some sources can include anemia. So that's your low red blood cell count. Pain can make you feel very anxious and very down. Reduced activity, insomnia, not getting a good night's sleep, the treatment toxicities, bone marrow suppression, these are all contributing factors. How do we manage this? It's great to exercise. And I'm not saying you have to, jog your way from New York to Miami, okay? You just have to do something. Walking, yoga. It doesn't have to be a very strenuous exercise regimen, but doing some kind of exercise program with your physician's approval can be most beneficial. Again, getting proper rest, Okay, napping if you have to, taking some drugs to help you with insomnia might be beneficial. Support, social networks, support groups. I think support groups are crucial, right? You might need professional counseling. And some of you may turn to prayer, meditation, spiritual support. Mindfulness based of stress reduction is important. Sometimes we have to resort to medications. They could be short-term. Very important to note that. Massage, aromatherapy, right? Reiki is also something that's used. Sometimes supplements with our approval, please let us know what supplements you're taking. Some patients who are very anemic may need transfusions. And then effectively managing other symptoms can make you feel better overall. And I do want to point out here on the slide at the bottom, at least 70% of patients experience fatigue. In my clinic, I would say it's close to 100% of patients have some report of some intermittent or profound fatigue, but only 20% tell their provider. Okay, so that's not a good thing. Please let us know about your symptoms, especially if they're not well controlled, or if you're thinking of, self-harm or just not living the life the way you want to live. We need to know about these symptoms at all times. Next slide, please. Infection prevention and treatments. So a compromised immune function comes from multiple myeloma, as the physicians mentioned. This is a cancer of the immune system, but also from treatment. Treatments can be immunosuppressive. So it's very important to have good personal hygiene. That includes your skin, your mouth, dental care, very important. Environmental control, we're all with this pandemic, we are aware of washing our hands, using Purell, avoiding crowds, avoiding sick people, wearing our mask as appropriate, keeping the social distancing when appropriate. Sometimes we utilize growth factors to bring up your specific white blood cell subset component. We do recommend immunizations, of course, no live vaccines. And folks, the COVID vaccine is not a live vaccine. Sometimes we have to give you medications for control of bacterial or viral infections. There is some new research that shows for patients receiving active myeloma therapy, especially induction therapy, that getting Levaquin daily for 12 weeks helped reduce infection and the sequela from infections. I think that everyone, if there's one good thing that came out of the pandemic, is that everyone has a thermometer at home, which is a good thing. So if you feel unwell or feel warm, take your temperature. Report a fever of more than 100.4 degrees, not 104, 100.4 degrees or greater, or shaking chills even without a fever. If you're dizzy, short of breath, have low blood pressure, we need to know about this. It may be a sign of infection, which could be very serious for all of you. This may warrant a visit to the emergency room if it's off hours, or if you can't get in touch with a healthcare provider. Okay, next slide. Pain prevention and management. We all know that pain can significantly compromise quality of life, and the sources of pain in the myeloma patient population is of course bone disease, probably number one. Neuropathy, that numbness and tingling, that can be associated with pain, and certain medical procedures can be painful. So how do we manage pain? Preventing it when possible, bone strengthening agents to decrease fracture risk, antivirals to prevent shingles or reduce the incidence of shingles, sedation before procedures, of course. The intervention depends on the source of the pain. Where is the pain? What's the intensity of the pain? This may include pain medications, some activity, maybe even surgical intervention, radiation therapy. Again, it all depends on the source of the pain. Complementary and alternative medicine can also play a role in pain management. But please, before you take even over-the-counter medications to control pain, you ask and discuss this with your healthcare team. A lot of medications for pain over the counter are cleared by the kidneys, and we don't want you to take these drugs for long periods of time. Again, tell us about any new bone pain or any chronic pain that is not adequately controlled. Next slide. So knowledge is power. And the IMF has many, many resources to help you learn. There are many things out there for you, folks. There's printed material, there are videos, there's a website, there are webinars, there's an e-newsletter, the Myeloma Minute, which I get all the time. These are downloadable resources, but you can also order them to be mailed to you at home. There's myeloma.org is the website. There's also a hotline, an 800 number that you can call to just request these materials. excellent, excellent resources to help you learn. And this is, folks, one of the reputable websites that I talked about. Okay, next slide. And of course, you're not alone. The IMF is here to help support you. And at this point, I would just open it up for questions or concerns. Thank you, Kelly.
Oh, you're so welcome. That was a great, God, there was a whole bunch of things that came down there I should have wrote down, but the main thing I just pulled out of there was exercise. And, you know, as Ann said, you don't have to run a marathon. Walking from your house to the kitchen, walking from your house to another room, maybe going down and getting the mail if it's not far away.
Yep.
Those little things add up to keep your body moving. You just have to do it somehow. And, you know, when we did that mindful meditation, it was just to give you a chance to breathe. And so often while you're going through these treatments, as my experience of working with patients for so many years, they do forget to breathe. They come in uptight. They're scared. And these are all admirable experiences that they're going through, but you just got to remember to breathe. So, Ann, you nailed that topic. Now we have a question. If anyone would like to take it, Sid, since you haven't been talking for a while, would you like to take that question?
So this, sure, it was a great presentation, Anne, by the way.
Thank you.
I think the question is, please talk about the newer drug that is being prescribed instead of acyclovir. I think we're talking about the valacyclovir. The brand name is the Valtrex. So anybody who is on a proteasome inhibitor like bortezomib or carfilzomib or ixazomib, and actually matters getting even worse with steroid, should be on herpes zoster or shingles prophylaxis. And I think we're talking about either acyclovir or valacyclovir. And that's what we definitely would recommend to be on. Even if somebody had Shingrix vaccination, we still put them on acyclovir or valacyclovir.
Should they be taking the shingle shot then?
It's a great question.
Is that a tricky one?
That's a tricky question. Many of the patients that already had shingle shots after being on the proteasome inhibitors and steroid and transplant, I have seen breakthrough shingles even after the shingle shot. So yeah, shingle shot definitely would be recommended, but while the patient is on active therapy, I'll recommend being on both.
What's the best pain medication for foot pain and leg cramps? Ann, do you have anything you'd like to add to that?
So leg cramping, it can be related to treatment. I think it's very important to stay well hydrated to help alleviate cramping. Exercise, as we mentioned before, can also help alleviate cramping. It depends on I mean, if cramping and pain, I mean, sometimes cramping is intermittent. And again, if it's really painful, we do recommend certain pain medications. Again, we don't recommend any of the NSAIDs for long-term use because of its effect on the kidneys. And some patients who are taking these drugs, they're not taking small doses, they're taking very big doses, which we want to avoid. So again, there are medications that we can prescribe for you to help with pain. Tylenol is always a good option. Unless you've been told not to take Tylenol, you can certainly take Tylenol to see if that helps alleviate the pain.
And another question for you, despite the Metamucil brand, lots of water, how best or treatment to deal with constipation issues?
Yes, I think it's very important to stay kind of on top of the bowel regimen. So I always recommend that if patients are having some issues with constipation, to jump on it kind of early. I do recommend a daily stool softener. I do recommend the gentle laxatives. And I do recommend having Miralax or milk of magnesia at home to be taken either every day or every other day. I think it's a very, you have to find out what works for you. So you have to kind of work with these over-the-counter agents to see which is the best combination and recipe for your situation. I think if these agents are not working, it is a phone call to the physician's group, because there are things we can prescribe for you or recommend over the counter. But I would think that you would want to tell us if it's been a long time since you've had a bowel movement. And again, trying to keep on top of this, having a bowel movement at least every other day is preferable.
Rafat, could we collect T cells for storage the same as we do harvesting stem cells?
Oh.
I mean, it is theoretically possible to do it. I mean, I think the logistic of collecting and storing and the cost of that may be prohibitive. I mean, I would say, the best time to collect it is when you're collecting your stem cells, because, when you do it, you collect the stem cells, 1% of the product is only stem cells. The rest is mononuclear cells. So it's rich with T cells. The question, can we, use these cells for, CAR T cells? I mean, I think a lot of hurdles need to be overcome. Can you thaw the cells and stay alive and stay effective? But I think it's possible. I mean, I think we need to investigate that, because I think one of the difficulty nowadays with CAR T cells is that, we taking patients who, unlike the clinical trials, have been heavily pretreated. We're not collecting, enough T cells. So when they're doing the manufacturing, they're requiring a lot more what we call vector to get these cells, produced. So if we can, use less cells and less vector, we can probably get more patients CAR T cells. So I think it's a great question. I think it's very important to be investigated. I don't see why it's not possible, but the question is who's going to pay for it, and how long do you store it for?
Correct. We have another question. Go ahead, Sid. Go ahead.
Sometimes in future, there are trials. One of us are going to also open the trial called allo CAR T. The T cells in patients who had received multiple treatment, they themselves are what we call is effete, senescent, and weak. And sometimes they may not be robust to fight the cancers. And that had been a concern. So the research is moving more towards collecting healthy donor T cells, third party, and then genetically snipped some of the antigens so it does not find the recipient's body as foreign and cause some other problems. So eventually it will be off the shelf, very quick turnaround from a healthy volunteer donor. And I think eventually in the future we'll be using more allo CAR T, not only for myeloma, many other cancers. And that would be the answer to having T cells available therapy all the time.
I see. Are there any alternatives to DEX at this time or on the horizon? Feel free to answer that.
I would
different
hope so.
steroids. Go ahead, Anne.
No, I just wanted to say, I would hope so, but
Mm-hmm.
I'm not familiar with any. I'll leave that to the physicians.
Yeah, I actually like methylprednisone better. It's shorter acting.
Yeah.
So I use it more than I use dexamethasone. And it's still a steroid, but it's shorter acting, it doesn't stay in the system as long.
See. Now we have a question from a patient here. What type of flu shot should one take who is over 65?
I think the CDC guideline is called a high strength, higher dose flu vaccine for patients who are immunocompromised and above the 65. And most of the institutions and pharmacies that offer it, higher strength flu.
Now I have another question that just popped up in the email. Will Medicare usually cover CAR T cell treatment? Has anyone had experience with this yet?
Well, they kind of cover it, but not adequately. I mean, I think that's, for example, our institution, we have has not been able to offer it to Medicare patient because obviously the cost is quite high, and unless you charge adequately, because there's associated costs. I mean, the CAR T cells is $450,000, but then you get on top of that the hospitalization, the lymphodepletion, to try to get the patient ready to get the CAR T cells, the post CAR T cells follow-up if they need certain drugs to manage the side effect. It can be very expensive. So there may be change in Medicare standpoint and reimbursement, but I don't know what your experience in Houston.
So I have used, of course, CAR T on trial, but when Avecma got approved, we had used in Medicare patients also, but this is a discussion that the myeloma physicians need to have the administration of the hospital and come to an agreement. And we had to come to an agreement, and we could use CAR T cells for our patients with multiple myeloma. Unfortunately, majority of our patients with multiple myeloma are elderly, so this is going to be a national issue, and it is being addressed as we speak at that level as well. So hopefully we'll see even better coverage in future.
I'm not presenting this right. I have a regimen of Eylea injections for retina degeneration and take Revlimid for MM. Does Revlimid have any detrimental effects on eyes?
Not that I know of. I personally do not know what's the Eylea injection, but I assume this is for the macular degeneration that there are injections available. But if the injection is done safely and no risk of any bleeding, one thing is you have to be careful when the patients are on Revlimid. We do recommend thromboprophylaxis. So some of the patients are on aspirin, some of the patients are on a stronger blood thinner, especially if somebody already had a history of blood clot. So this has to be divulged and discussed with the ophthalmologist if you are on a blood thinner and getting an eye injection, and that's something that has to be discussed with the ophthalmologist and see how that interacts. Revlimid per se, no, but associated anticoagulation might change the regimen.
Okay, Rafat, you're nodding your head. I have a question here. Please comment further on getting treatment right at first relapse. Would you elaborate?
Well, I mean, you know, again, patients with multiple myeloma, they're going, unfortunately, to relapse. And when you're relapsing, you know, your myeloma protein goes up or your light chain goes up. I wouldn't, you know, jump the gun at the first rise in your myeloma protein. And actually, most clinical trials and most guidelines require you to confirm that there's a rise, consistent rise in the myeloma protein and the light chain. So I would bring the patient a month later to confirm that the light chain and the M protein is really going up. At that time, obviously, we'll decide, you know, okay, now you're relapsing, you know, we try to do workup, sometimes, you know, do a PET scan or a bone marrow to just look at the burden of the disease and decide on the appropriate therapy. But, you know, again, I mean, I think most clinical trials were done based on biochemical relapse, you know, rise in the myeloma protein, rise in the light chain. So you have to, you know, to show that, but not one reading. You have to confirm that. You have to come back in at least a couple of weeks to a month to show that this is not a transient rise, because sometimes you get, for no good reason or understanding, a rise in the myeloma protein, but then it comes back down, you know, so that's, I think, important.
All right, Sid, one final question out to you. We talked about a stem cell transplant being completed and, you know, the stuff you have to go through within that process. The question is, when is a tandem cell transplant recommended, and what are the indicators? Are there simple indicators for that need?
So tandem transplantation basically means we collect enough stem cells for 2 transplantation or even sometimes more, and use the second transplantation right back to back. So we do the first transplantation, patient's counts recovered, within 30 to 40 days, we just go with the next transplantation planned. This is different from the second transplantation, which usually we use when the disease relapses, and then we use the second transplantation. There have been some papers, especially from Europe, where they showed that tandem transplantation does have advantage over a single transplantation. However, subsequent papers have not shown that efficacy. We did a large trial, above 700 patients, called BMTCTN 0702, where we did single transplant followed by Len maintenance, tandem transplant followed by Len maintenance, and transplant followed by consolidation followed by Len maintenance. And at the end of the day, we found there was no difference among the 3 arms. So we say that single transplant followed by Len maintenance is the standard of care, at least in this country, and we are not recommending tandem transplantation for everybody. There have been some papers, especially in chromosomes, high-risk chromosomes, like translocation 414, where there might have been some added advantage of a tandem transplantation that improves the progression-free survival. So I think in general, we do not recommend tandem transplantation, but by case-by-case basis, we can discuss that with the patient, and you should bring it up with your myeloma specialist.
That's excellent. And, you know, we've heard so much about that in the beginning from Arkansas, I believe is where it was coming from, about tandem and these multiple stem cell transplants, which, as you just said, might not show efficacy as other treatments would today. Miko, is that about where we are?
We can probably do a couple more.
All righty. Do you guys see the anonymous attendee question about their remission and so forth?
I think there's a question, is there a pill similar to Kyprolis? Everybody's need is different, but to just simply answer, Kyprolis or carfilzomib is a proteasome inhibitor, and there is a pill called ixazomib or Ninlaro, which is an oral proteasome inhibitor. Whether that would be appropriate for in this particular situation, I would not know, but yes, there is an oral proteasome inhibitor that is available in the market called ixazomib or Ninlaro.
And that would potentially be easier on some patients and not easier on some patients. It's that kind of thing.
Correct.
Yeah, I see. All right. Rafat, do you want to tell us of any important or upcoming trials you're doing at Indiana?
Yeah, again, I mean, I think you heard about the allo CAR T cells. We also interested in, we call it an allo CAR NK, not T. So there's a cells in our body called natural killer cells. And the natural killer cells are important in getting rid of foreign cells like cancer cells. And so there's a trial we're collaborating with a company where we take donor natural killer cells, take their ability of recognizing, the patient's body, but only teach it to kill myeloma cells. So I think that's a very exciting clinical trials we like. The other thing is that we looking at a way to make myeloma cells visible. There's a molecule on myeloma cells called CD28, and CD28 is very important in sort of kind of hiding the myeloma cells from the immune cells. And there's some pill that you can use that will sort of inhibit that expression and make the myeloma cells visible. So we like to combine that with, other myeloma therapy to make it more effective. So, cellular therapy, I think, is incredible. I mean, the responses are incredible. What we need to make sure is that we make it safer, more specific, and lasting. And so that's some of the research we're doing.
Sid, what do you have going on in Houston right now?
Yeah, so allo CAR T was on the table. And then one thing you probably have already noticed that Abecma is now approved. There is another CAR T that is going to be approved, but still the need supersedes the supply. So we still need more trials in the CAR T arena. So we have more auto CAR Ts opening here as well. But more importantly, we are going to also open a bispecific antibody that with or without daratumumab combination. So that is very exciting. Also targeting another, other than BCMA, called GPRC5D, another target on the plasma cells. So those are the trials that we are hoping to open, hopefully by end of this year or early next year. They're already through the regulatory process and approved.
That's fantastic. You never leave a stone unturned, Sid. That's for sure when you do your stuff. Hey, Ann, what's going on up there at your place? I know you're working with 2 other doctors there. Is there anything you want to share with what's going on?
We also have many CAR T clinical trials, and we also have the BiTE therapies in clinical trials, lots and lots of clinical trials. And we have a whole research team, as I'm sure that the other physicians do as well. So many clinical trials, accruing actively for patients with myeloma.
Oh, that's great. Well, all of you had such informative presentations today. As you know, I've done this for a long time, and so have you guys, being doctors and nurses, but I really learned some new things today, and that's good for me to go out and share with the patients. We have 4 people of myself that visit 120 some support groups across the country. And by getting this information out, we have more guide, as it were, to excite people as opposed to them being down and out. But what I really want to do here, after thanking everyone, which I just have, is that your feedback is incredibly important to us today. At the end of this meeting, a feedback survey will just pop up right there on your computer. It's not Big Brother. It happens all the time. And you email it shortly, you fill it out quickly and send it right back to us. And that is it. I like everyone that speaks here. I like to hear what you guys think. I share it with them. We do all work together, so please do that. And finally, I'd like to thank our sponsors whose generous support has made this possible. Amgen, Binding Site, Bristol Myers Squibb, GSK, Janssen, Karyopharm, Oncopeptides, and Takeda Oncology. Thank you. All of you have a good Saturday. A lot of good college footballs on if that's what you watch. But go and enjoy your Saturday. Thanks so
Bye-bye,
much,
Kelly.
everyone. Bye-bye.
Thank you.
Bye-bye, Kelly.
Bye-bye.
Thank you. I have to decide between Texan and Chiefs now. I don't know.
Uh-oh.
Yeah. So anyway. Okay. Thank you.
Bye, guys.